It's a pleasure to be here, and I'm very delighted to be interviewing one of the brilliant minds in hematology. I would like to start by asking you to introduce yourself, to tell us your training so far, having studied medicine to this point of being a specialist in hematology, what your career path has been and the jobs you've done over the years.
Okay, thank you. Well, I'm Angela Thomas, and I trained in medicine in London and actually did all my haematology training in London as well. I started at the Royal Free Hospital and then moved on to St Bartholomew's Hospital and then did a PhD at University College London. And as I was coming to the end of that, a paediatric haematology job came up in Edinburgh, and I thought, well, seems like quite a long way away from London, but I'll give it a go. And I'm delighted I was offered the job, which I accepted, and started that on the 1st of the 1st, 1993. So that was at the Royal Hospital for Sick Children in Edinburgh.
What was your main drive to get into hematology? What was your curiosity? Was this something about the specialty that got you really interested in hematology?
Well, I think as a student, when I was at Barts, haematology was, the clinical side was looked after by the oncologist and a guy called Bodley Scott. The SHO rotation at Barts came up, and one of the parts of the rotation was 4 months oncology with Professor Lister. And so I did that, and it completely fascinated me. And I remember there was a lady who had CLL with very marked hemolysis. And in the morning, her blood count would be one result, and then it would be repeated in the evening, and it would be very, very different. And I didn't understand, so I went down to the lab, and somebody explained that it was to do with counting the nucleated red cells, and the machine couldn't cope because it was an old one, a different one on call from the one that they ran during the day. And I'm thinking, crikey, this is all sorts of stuff I hadn't any idea about. And somebody very kindly said, well, do you want to have a look at the blood film? And pointing out the difference between the CLL cells and the nucleated red cells. And I said, well, I've got anything else to see? So they showed me the leukemia, and then they said, well, I'd like to see malaria. And I thought, this is really cool. So I think that's what got me thinking I'd really like to do haematology. I then, after that rotation finished, did some more general medicine. And then the posts came up at the Royal Free, which I applied for, and very fortunately got one of those, and that was it. That's what I wanted to do.
From your point of view, do you consider hematology a career or a passion?
When I first started, it was definitely a career, but has developed into a passion. The thing I love about haematology is that if you understand the physiology, if you understand, well, now I suppose all the molecular stuff as well, just looking at the blood film doesn't tell you everything, but it gives you a jolly good start. And I think as time has gone by and we've learnt where things look the same but they don't behave the same, as we've drilled down, there'd be more and more exciting things to find at a molecular level. But it's still the first thing, you need to look at the film and say, what is going on? And that's what I have found has been so exciting, that it's, you can make a very good start all by yourself.
I wondered, given your very long career, what do you think would be the greatest moments you've got in hematology from a personal point of view?
Greatest moment? I suppose later in my career, out of the blue, I got, you get emails from people saying, don't forget to go to this and don't forget to go to that. And I got one saying, don't forget to go to ASH. And I thought, oh yeah, look at this. And then I realised I was being invited to run a whole teaching session on malignant haematology, and would I like to speak as well? And I thought, and share the session. And I remember thinking, wow, that's amazing. That was quite a big moment. And my immediate thought was, can I really do this? And I thought, well, I better really do it because I've been asked to do it. So that was quite a moment to be chosen. And I emailed to say yes, and then got such a fantastic email back from the guy who'd asked me to say he was so pleased, and that made me very proud. And I guess the other thing I should say is I was very proud to be asked to be president of the BSH, which was 2012, which again was a surprise and an honour, and was great fun.
What do you think are the greatest things that have happened in hematology in the last 60 years? I say 60 years because the BCH is 60 years old.
Well, first thing, we just had the morphology, and then as time went by, we had immunological staining. There was more sensitive techniques than just chromosomes, being able to look at actually the mutational changes and so on, and then relating the morphology to the immunology, to the changes, and then actually to patient behaviour or disease behaviour in that patient, to say, well, actually, if you have Philadelphia positive leukemia, you're going to do worse than if you don't have it. And just realising that putting all these bits of information together and using, in a way, a multidisciplinary approach, you got a better understanding of what was going on and really a better prediction of what was going to happen. And so what went on from that, I guess, is that being able to drill down into the genomics to say that actually if you can see what's gone wrong at a molecular level or at a gene level, then you can work out perhaps why those cells have become leukemic. You can predict which patients may do better or worse from level of disease. You can see why that patient may become resistant to drugs, and indeed you can then look to make some of those unique changes or recurrent changes in leukemia into drug targets, hopefully reducing toxicity, improving efficacy. And then alongside that as well, of course, we've had looking at patients, the patient's own genetic makeup, pharmacogenomics, to say, well, that patient, we can tell from that mutation is going to be more sensitive. For instance, with vincristine, there is a mutation which makes a patient more sensitive. Fortunately, it makes leukemia more sensitive as well, but it means you can adjust the drug dosages. So where we've come to now, that if we can understand the pathogenesis of leukemia, then it allows us to not only to optimize the therapy so that you can balance the risk-benefit in favour of the patient, but the chances of actually improving outcome are also there at the same time.
The BSH is 60 currently, and it's quite impressive. It's come this long way. What role do you think it plays, or what's its place in haematology practice in the UK?
I think it's a place where haematologists have come together. Haematologists, I think, initially grew from physicians with an interest in haematology, and also from, say, paediatricians or an obstetrician who may be particularly interested in clotting. But it hadn't been looked on so much as a clinical specialty. And then as it came out of the laboratory and across the laboratory clinical divide, a truly translational medicine at that early stage, there needed to be a place where haematologists could say, yeah, we're all together in this and we can learn from each other. But looking at hematological disease in particular, we're talking about advances in therapy and so on. We talk particularly about malignant disease. I was working at the Royal Free at the time of Hep C and HIV were being identified. And so spoke to patients then who remembered having no treatment for haemophilia at all, then having this magic factor VIII, and then actually having these terrible adventitious agents give them an awful disease. Moving on from that now, obviously the concentrates are much better there. Many of them are made through molecular technology, more advanced technology, but also the most feared problem, I suppose, in haemophilia A anyway, is development of inhibitors, and looking at using the new technologies, in fact, which have mostly been used for immunological or malignant disease, that of monoclonal antibodies, but using that same technique, being able to overcome by a subcutaneous injection once every 2 weeks the patients with inhibitors for haemophilia A is absolutely astonishing, completely groundbreaking for these patients. Huge advance. And you do think that some of those ideas probably came from saying, well, you can use it to bind specific targets and we're going to use malignant targets or inflammatory targets, and somebody thinking, oh, well, we could use coagulation targets as well. And so using those advanced therapies between very, very different diseases is exciting.
Yeah, that's absolutely right. I just wondered, you mentioned about this in hematology. That brings me, I was in a meeting recently and I looked at social media where we are currently in the modern world and how hematology can play a role. And I immediately linked myself onto the blood bank guy and some podcast and book of hematology, which other clinicians can see and address basic problems. Do you think there's a role for this, the role of social media and web-based pages and things that other clinicians can be able to also see and address so that hematologists are not overburdened? Because sometimes you start to wonder if your hematologists feel overburdened by the amount of calls you do get.
Yeah. There's no doubt that as a hematologist, if you're working on your own, there you have the patient in front of you, you are the one looking down the microscope, you are the one making the diagnosis, and sometimes it feels pretty lonely. And it's really nice to be able to say, what do you think? And so being able to share the stories, the pictures, particularly the blood films, and all the other advances that we've discussed, the immunology and the genetics and so on.
And that brings me to the next question. Where do you see hematology in the next 60 years? By then, BCH is over 100 century years old.
120.
Yeah, 120.
I suppose it will be looking at the technological advances that can identify those molecular motifs or those mutations very easily, not necessarily bedside diagnosis, but rather than having to send them away and wait for a bit, that will be much more easily accessible, or the range of abnormalities will be greater, more accurate, more reliable. I guess as well as time passes, we often at the moment have the basic information and then are trying new therapies, but we don't yet have the long-term information. So as time goes by and you gather the post-treatment information and look back wisely, then you can say, well, actually, this was a bit different, or this was the way that seemed to work best. And so using that knowledge will make the untreatable or much more difficult to treat much more treatable. So that's one area, but I guess the other area which really does need to improve is access to life-saving therapy or techniques. And that really is going back again a lot to things like the hemoglobinopathies. And it would be fantastic if one could develop a therapy which, although at the moment very sophisticated and not available for many, could actually be easily delivered, effectively delivered on a very large scale.
And that brings me to the question of what you have to tell an aspiring hematologist, a CMT1, a FY2 out there, or even a ST3 like myself. What would be the advice you give them?
Okay, so the advice, first of all, I suppose, is to not give up. I mean, that's sort of fairly obvious. If there's something you want to do, something about which you think you will become passionate if you're not passionate now, then do it. Don't be put off by people saying, oh, no, it's not what you want to do, or this is a good avenue. I was advised many, many years ago when somebody said to me after I'd done my SHO post, what do you want to do, Angela? I said, I really like to do haematology. And they said, oh, that's quite difficult. Cytology is quite good for a girl. And I remember thinking, I'm not going to do cytology. I am definitely doing haematology. So if there's something you want to do, then you should pursue it. Sometimes you have to change. So that's one bit of advice. But I think the other bit is don't underestimate how important it is to work with other people. And that's people, haematologists, immunologists, virologists, all sorts of people can actually help understand the whole picture. And to, I guess, work out things so that if they, as I said, they don't quite make sense to you, don't just accept, oh, well, then this is just one of those things. Just say, but why? Why should this not work? And when you go to meetings, it's very easy to always go to the things that you know about. Think, oh, well, I know about that, I'll go, and it'll just confirm all that I know. But go to the things which sound a bit new and exciting, perhaps not scary, but just, oh, I don't know anything much about that. What can I learn from that? And you go and you think, oh my goodness, I hadn't even thought of that. And you can apply these new ideas to some of the problems that you've got. And sometimes they will, come to fruition. So I think it's, pursue what you want, climb your own career ladder, not another one somebody else thinks you should be climbing, and worry away at the things that don't make sense, and make good collaborations and work with people. And then, of course, work hard and pass your exams and all that. But I think for me too, the advice I was given, about, don't forget to have a family and family life on the way, has been huge, huge support. I think a career can be all-consuming, but you have a duty to yourself and actually to your patients and undoubtedly to your colleagues not to just do that and nothing else.
Professor Angela Thomas, that was incredible. Thanks for this wonderful section. We're very inspired. Thank you very much.
Thank you.